symposium. As you mentioned already, this is a little bit difficult topic, but in my opinion, it is like bike riding. Once you learn it, you will never forget it. So in this 1 hour, I will try to introduce you with the decoding of arterial blood gas analysis and ventilator setting.
Awesome. So
we can start. When you are looking at the arterial blood gas analysis, you can see that you have parameters to evaluate. In that case, you will see that you can see the ventilator status of the patient, you can see the oxygenation status of the patient, and you can see the acid-base status of the patient. There is an interrelationship, but less confusing if you consider these parameters separately. What does it mean? That when you approach to this ABG interpretation, first you will have to assess the ventilation and the oxygenation status of the patient. Afterward, you can assess the acid-base status. And in the end, you can have a clue about the volume, osmolality, electrolytes, and etc. When you look at the arterial blood gas, you can see that there you have a measured parameters and you have calculated parameters. In the measured parameters, you have the pH, which is showing you the acid-base status of the patient, and normal value is 7.38 to 7.42. You have the partial pressure of carbon dioxide, which is normally 35 to 45 milliliters of mercury. And you have the partial pressure of oxygen, which normally is 70 to 100 milliliters of mercury. When you will look the calculated parameters, you can notice that there you have the bicarbonates, the actual bicarbonates, which normal value is 23 to 25 milliequivalents per liter. You have the bisexase, which normally is -2 to +2. And you have the saturation with oxygen of the patient, which normally is 96 to 100%. Next, please. So, in this slide, you can see how the arterial blood gas analysis actually look like. So you have the measured, you have the calculated parameters. And in the lower part, you will notice that you have some gradient, which is big A minus small a letter. That gradient is showing you the difference between the oxygen pressure in the alveoli and in the capillary of the patient. And when you look these arterial blood gases, remember that you always should notice and see the inspired fracture of oxygen and the hemoglobin of the patient. This is chart who illustrate 4 categories of blood gas diagnosis. So if you think of your patient as falling into one or another category, therapy can be simplified. Combination can occur and require multiple regimen. So let's start with the respiratory acidosis. Acidosis, it means that the pH is decreased. And because in this case you have respiratory disturbance, you will see the partial pressure of carbon dioxide, which is increased. When you have respiratory alkalosis, that means that the pH is increased and that the PCO2 is decreased. When you're looking at the metabolic acidosis, acidosis shows that pH is decreased and you have bicarbonates in this disturbance, which are decreased as well. And the last one is the metabolic alkalosis, when you have increased pH and the bicarbonates are also increased. In the next slide, I will show you how this is connected with the respiratory and the metabolic problem handled. Naturally, the respiratory problems are handled via lungs. So that means that with the ventilation, we are controlling the partial pressure for carbon dioxide. On the other hand, metabolic or bicarbonates problem are handled naturally via the kidney. So kidney lose the hydrogen ion and reabsorbs the bicarbonates. Bicarbonates is the transport from and of CO2, hence should move in the same direction. These problems do cause shifting of electrolytes so that electrolytes are either excreted or retained by the kidney. On the next slide, you will see some causes of respiratory failure. So we have some problems with the respiratory center in the brain. It could be head injury, it could be drug intoxication. You will have respiratory disturbance. If you have some problem with the neuromuscular connection, then you have problem with the spinal cord, maybe you have some injury. You may have problem with the thoracic below. You may have problem with the upper and lower airway, which will give you some condition of the lungs. And you may have problem with the lung parenchyma, which will give you the status of the alveoli like acute respiratory distress syndrome. Next slide, please. So here are also some causes of respiratory abnormalities. Normally in acidosis, we have the decreased pH and increased PCO2. In alkalosis, we have increased pH and decreased PCO2. Respiratory, acidosis, and alkalosis are based on the CO2 level, and treatment must be directed at the etiology. Since artificial ventilation is the final pathway of hypoventilation, and modes of improving ventilation should be attempted prior to intubation and ventilation of the patient. In some cases, only experience can teach you when intubation is necessary. So let the pH and the PCO2 guide you how you should serve. If we look the patient that he has some progressive disease or one which can be reversed, is the first question. For example, usually in obstructive pulmonary problem who are causing respiratory acidosis can be really treated with IV steroids, inhaled bronchodilators, and also you have some other technique who can be useful. Though in the acute phase, they play a more complementary role. There is another trick for lowering CO2, which will be explained in the ventilator section and in the next slides. Drug overdose and anesthesia. Back please, Michelle, thank you. Drug overdose and anesthesia take time to leave the body, and the intubation and ventilation are necessary until detoxification occurs. Previous slide, Michelle, just something. Thank you. Traumatic flail chest injury is also another reason for intubation and ventilation, but there is also another indication from the ventilator to stabilize the chambers from breathing. Neurological disease, myasthenia gravis, Guillain-Barré. Obviously, this will demand initial ventilator support until the disease is resolved. Alkalosis represents another problem in these patients. With increased respiration, can try and become apneic, causing the PCO2 to rise and producing and then cannot be corrected in a reasonable amount of time. Always have that in mind. You can never fix something in a second. Next slide, please, Michelle. So, ventilator. That is the device which controls the PCO2 by producing a tidal volume at a certain respiratory rate. Some forcement to drive the tidal volume out of the machine and into the patient. This force is known as pressure, and the ratio of the volume per unit is known as flow. The tidal volume, the pressure, the flow, and the respiratory rate are the 4 parameters of ventilation. So when you are setting one ventilator, you should always set these 4 parameters: tidal volume, pressure, flow, and respiratory rate, because changes in pressure, flow, respiratory rate affect the tidal volume, which will change the PCO2. We have 2 types of ventilators. In use today, we have pressure ventilators and volume ventilators. pressure ventilators is controlled via the pressure. And that means that we are setting the pressure, and depends of the patient condition in the lung, like compliance and resistance, certain tidal volume will be achieved. This is not good in clinical settings because it requires constant presence of a medical specialist due to the changes of tidal volume according to the lung condition. For example, if the patient is having some secretion of spasm, the stated pressure of the machine will deliver smaller tidal volume. That's how you should always be present and set the adequate amount of pressure to achieve the desired tidal volume of the patient. On the other hand, in volume-controlled ventilation, we set the tidal volume. We set the flow and we set the respiratory rate. And the machine will generate as much pressure as it needs according to the patient condition of the lungs, again, like compliance and resistance, to deliver the preset tidal volume that we set. So the machine can trigger different pressure values to achieve the tidal volumes that we set. These are the two basic types of mechanical ventilation. We set the highest pressure in the alarm, so the machine will alarm if higher pressure is needed and not harm the patient. This will protect the lungs for paratrauma. In the next slide, you can see the volume ventilator setting type, how it looks like. So we will balance the tidal volume. They are circled with black circle in the picture. We have the respiratory rate and we have the flow that we will set. And we will accomplish the fourth one in these circumstances. That will be the pressure. Depends on the condition of the lung of the patient. It will trigger different pressure, so it will achieve the desired tidal volume. Purpose of mechanical ventilation. The purpose of mechanical ventilation is to control the alveolar ventilation, which controls the PCO2. And remember that alveolar ventilation is the difference between the tidal volume and the dead space ventilation, multiplied respiratory rate. There are four factors that will influence the alveolar ventilation: the tidal volume, the pressure, which is amount of the force necessary to deliver the desired volume, and we have the flow, speed of volume delivery. And in the end, we have the time, which is the respiratory rate. Next one, please, Michelle. Thank you. There are two types of volume mechanical ventilation for control the partial pressure of carbon dioxide. Continuous mechanical ventilation. The first part is constant ventilation, as you can see in the equation. And in the second part is the changeable that will be preset tidal volume only when the patient is triggering the ventilation. So what does it mean? That we have alveolar ventilation, which is respiratory rate set it in the machine, which will derive tidal volume also set it by the machine or by the doctor. But in this, we should always add the respiratory rate of the patient. And always when the patient is taking breath by his own, the machine will trigger tidal volume that we set it. And in the other hand, in the synchronized intermittent mechanical ventilation modus, as you can see, there is a little difference in the equation. We have the same first part. We have the respiratory rate set it in the machine and the tidal volume set it on the machine by the doctor. But in this one, in this modus, you can allow the patient to breathe by himself, on his own, because every time he will having respiration on his own, that will be with tidal volume that he is achieving by himself, not that will be stated by us, by the doctor in the machine. So if you are seeing these two equations, I would like you to ask a question. rhetoric one because I will answer it in the end. When this synchronized intermittent mechanical ventilation is like continuous mechanical ventilation. And the answer is when the respiratory rate of the patient is 0, because that's how it will get the tidal volume, set it on the machine only by the doctor, and he cannot breathe by himself. Since he is not breathing by himself, we have continuous mechanical ventilation. As I mentioned, we can correct the PCO2 with the ventilator. Correction of the respiratory acidosis and alkalosis when the patient is on the ventilation, we can calculate it with the above equation. A ventilation produces a certain amount of carbon dioxide as determined by blood gas analysis, which we are possible to calculate. Then we can set the ventilator, on the modus that we like to achieve our desired PCO2. For instance, if the patient is having PCO2 of 50 and tidal volume of 500 with respiratory rate of 10, what is the partial pressure of carbon dioxide that we want to achieve? Normally we set it's 35 to 45, so we will put here 40. And if we take the equation, we will see that we can set the ventilator with 10 respiration on 625 tidal volume, or we can set the ventilator on 12 respiratory rate ventilations with tidal volume of 520. And in the end, we can set the ventilator with 15 respiratory rate with tidal volume of 415. And depends on the patient condition, we will choose some of this one and hoping that we will correct the PCO2 to the desired one. I would like to speak a little bit about the PEEP. PEEP is the positive end expiratory pressure. Because of this increased pressure and the end of expiration, the alveolar volume never fully deflates and consequently stays inflated a bit. Whether or not this is the action which will cause the PCO2 to rise is not known, but since it works, it's better if you are using it. There is the use of super PEEP and mega PEEP, which is 20 or 30 centimeters, but in clinical medicine that are extremely hard oxygenation cases and usually they have really poor outcome. We should look at PEEP as surfactant. We know that surfactant keeps the lungs open. So consider PEEP as artificial surfactant. That means that he will give tension to the alveolus and they will keep them open, never give them to fully deflate. PEEP does the very thing which can be considered as artificial surfactant. But remember that patients with emphysema already have increased functional residual capacity and they may not respond well to PEEP. So when you have patients with emphysema, you should think about the PEEP twice. If high PEEP is used, venous return to the heart may be impaired, producing low cardiac output. This is one of the complications when you are using PEEP. The other complication, which is a little bit bigger problem for me, if you are producing barotrauma and pneumothorax. Sometimes you can put prophylactic bilateral chest tube, but you should always keep in mind to be careful with this PEEP. How can we set the best PEEP? We know that the best compliance of the lung is approximately 40. So whenever we have PEEP, which is give us the compliance of the lung of 40, we should keep that PEEP. How to get this one? It has been shown, back please, Michelle. Thank you. It has been shown that the PEEP level, which gives the best compliance, is the best PeO2. or the partial pressure of oxygen. Compliance is nothing more than the measurements of the lung elasticity. The lower the compliance, the stiffer the lung. So best PEEP, remember, is when we have compliance around 40. There you have the equation, and if you calculate it, the compliance with tidal volume, with plateau pressure and the PEEP, and when you are using it with the parameters that you have set it in the patient, you can get the best PEEP. When you achieve with the equation compliance of 40, that is the PEEP that you want to have it. For example, if we have tidal volume of 500 with plateau pressure of 16, and we have set it PEEP of 4, that will give us the compliance of 40. So in this case, we will keep the PEEP of 4. Next one, Michelle. Thank you. Another way to adjust the best PEEP is with central venous catheter and the continuous measurements of mixed oxygen saturation. The highest oxygen saturation will be considered that is the best PEEP for the patient. Patient must breathe on his own and he must be able to control his PCO2 if we want to wean him from the ventilation. Because once best PEEP is applied, we should not touch until inspired fraction of oxygen is lowered around 30. And when we achieve this one, and we are sure that patient can maintain PCO2 and is fully awake, we can try to wean him from the ventilation. Since there is no tidal volume or respiration from the machine in the CPAP mode, the patient must breathe on his own because every ventilation will be from the patient by himself and we cannot help him with the machine. If patient stop breathing, we will have to place back him on the other ventilator settings that we were discussing before. In this boomerang video, I would like to show you how PEEP actually works. Please play, Michelle. Thank you. So you see, here we have certain amounts of tidal volume with the ambu bag reinflated, and we can see that the gloves or the lungs will be fully deflated. So that means that in every next breath, we should use bigger force to achieve the tidal volume. Next one, if we apply some PEEP, we can have tidal volume, but the gloves or the lungs will never fully collapse. And that's how it will be easy to trigger every next tidal volume ventilation. This is something when you also have to have in your mind when you're trying to wean patient from mechanical ventilation. This is the dead space ventilation and tidal volume ventilation ratio. This is the reflection of efficacy of ventilation. So if you have normally the ratio of dead space ventilation to total ventilation is 0.35 or less. But if you have increased dead space, so there are abnormally large areas which are being ventilated, but which are not exchanging gas, the VD-VT ratio will increase. VD-VT ratio is calculated from the following equation. For example, what is the dead space ventilation if patient is having tidal volume of 800 and partial pressure of carbon dioxide of 50 and partial pressure of excreted carbon dioxide, this is the new variable that we are seeing here in this slide, of 30. Then we will calculate the VD-VT ratio and we will see that this patient, which is having tidal volume of 800, PCO2 of 50, PCO2 of 30, will have less than 0.6 VD-VT ratio. If patient is having 0.6 VD-VT ratio, it can be weaned from mechanical ventilation. Next slide is the example that I was telling you about. So we have tidal volume of 800, partial pressure of carbon dioxide of 50, and partial pressure of excreted carbon dioxide 30. If we calculated this, we will see that patient is having 0.4 VDVT ratio, and that means that the patient can be weaned from the ventilator. I would like to move on some little bit more interactive part. It was enough me speaking. So if we have these ABGs, the pH is 7.39, the PCO2 is 39, the bicarbonates are 23. I want to hear your opinion. What do you think? What is this blood gas? Michelle, show you. So this is normal. You can, yes. Because everything is in the normal border, that means that this patient is having normal arterial blood gases. Move on, Michelle. Thank you. We will continue with the first case scenario. We have a 44-year-old man who has been admitted in the hospital for 3 days with pneumonia. He was recovering very well, but has become dyspneic, diaphoretic, hypotensive. He is on nasal cannula with 3 liters of oxygen. When we maintain his arterial blood gas, they show that pH is 7.41, PCO2 is 20, PO2 80, bicarbonates are 12, hemoglobin is 13, and the saturation with oxygen is 95%. In the beginning, I would like you to characterize his state of oxygenation. And when we are looking his oxygenation status, we should look about the PO2, which is 80, and that is showing us that the patient is having good oxygenation. How would you characterize his state of ventilation? When we are trying to see how his ventilation is, we will see the saturation of oxygen, that is 95, and we have PCO2, that is 20. Excellent. Yes, we have compensation here. So, in the end, I want you to see his acid-base balance. pH 741, PCO2 20, bicarbonates 12. And how would you characterize his state?
All right, guys, so this is an open-ended question. So you could go to the link that we were using earlier and you could see your responses come up live in the PowerPoint. And don't worry, they're all anonymous, so you don't have to be stage fright.
Compensated acidosis. Compensated respiratory acidosis. I agree with the first one. I don't agree with the second one. Let's go if compensated acidosis, correct, but it's compensated metabolic acidosis because he was having decreased bicarbonates, and you see, and he was having pneumonia, so he's compensating with increased respiratory rate. So we have normal pH, PCO2 is with respiratory alkalosis, that means that he's compensating, and we have metabolic acidosis because carbonates is decreased. Thank you, guys. Next scenario. Patient is found pulseless and not breathing. After CPR, he responds with pulse and starts breathing on his own. In this case, we also maintain arterial blood gas, and we will obtain that pH is 6.89, PCO2 is 70, PO2 is 42, and bicarbonates are 30. In this case, the saturation is 50. How would you interpret this? Look the numbers one more time.
Yeah, look at the numbers,
Yeah.
get your answers, and we'll start the poll. Okay, ready guys? So it's going to be open-ended. So hopefully you wrote those down. There we go. Oh, we got one. Okay, the poll's open.
Good. Yes.
You guys are much better at this than I was when I was in med school.
I don't know if this is because of the lecture or they already knew it before, so.
Maybe a little bit of both, who knows?
Really good, guys. Yes, that's true. You're correct. So we have acidosis, we have respiratory acidosis, and we have metabolic acidosis as well. This is very bad condition of the patient. What intervention would be appropriate for this patient since he's having very low saturation, very low pH, and he's having uncompensated respiratory and metabolic acidosis? What you will do next? Yes. But he's already having CPR and he resolved the pulse. Yes, provide oxygen and bicarbonates. Yes, correct. Intubation and oxygen. So remember that you should never hurry with intubation of the patient. But in this kind of circumstances, it's better if you do that. The third scenario, we have a 47-year-old woman with diabetes. She is insulin dependent and was brought to the emergency department by ambulance. She was semi-comatose and had been in for several days. On current medication with digoxin and thiazide diuretics for chronic heart failure. When we obtain blood gas of this patient, we see that she is having pH of 7.4, PCO2 of 31, PO2 of 84, bicarbonates of 90. Let's see the electrolytes. We have sodium, we have potassium, chlorides, we have the glucose, and we have the lactate and urine ketones. This is probably very familiar to you. So, is this normal? If we see the pH, we will say, yes, it's normal. But remember that we have mixed acid-base disorder. We have normal pH, we have decreased PCO2, and we have decreased bicarbonates, which is showing us that we have respiratory alkalosis, and metabolic acidosis. It's mixed acid-base disturbance, so that's why we will have compensated pH. And because the pH is normal, we can not distinguish in the primary cause it's the respiratory or the metabolic disturbance. Diabetic ketoacidosis. It means that it's metabolic acidosis, but we should calculate the anion gap if we want to be sure about it. How can we calculate the anion gap? We have pH of 74, which is normal. Next one, please, Michelle. Thank you. To confirm this, we calculate the anion gap. In this slide, you have the equation for the anion gap, which is showing the sodium, the chlorides, the bicarbonates. If we use the values of the patient, we will see that this patient has anion gap of 34. And that is the value that is showing us that this patient is having metabolic acidosis. Because every time when you have increased anion gap, more than 16, it means that patient is having metabolic acidosis disturbance. Anion gap acidosis in this case, secondary to diabetic ketoacidosis. And she may have metabolic alkalosis in the settings of thiazide diuretic use. Before we get back to this simulator, I would like to show you the last, go Michelle, thank you. On the last one, thank you. Here it should be some picture, but never mind. Go back on the simulator, on the Draeger simulator, Michelle, please. So in this slide, I'm showing you some website. This is the website when you can practice mechanical ventilation by yourself. Is the Draeger Evita mechanical ventilator. And if Michelle like, now we can switch to my screen share, and
Yes.
I can show you how does this work.
I will stop my screen so you could share yours. This is kind of like the coolest thing I've seen, that you get to like play around with it like it's real life.
And you can share with everyone, Michelle, or you can go back to the slide when they can see, so they can.
Yep, I'll write it in the chat.
Yeah, perfect. You can put it in the chat. So when you open this web page, you can see that there is Draeger Evita simulation when you can practice mechanical ventilation or on your own. I will show you some things because we don't have too much time. In the beginning, you can get started. So when you go to this one and when you start, you can see that you have some basic things that you always have to occur, like to put the ventilator in the electricity, to set the power supply, to provide a gas supply, which is very important for the patient, to have oxygen, to have air, to take and put the flow sensors on the expiratory valve so they cannot be blocked and you can damage the patient. You can set the breathing circuits, you can put the tubes in the ventilator so you can connect to the patient, and you can start the device. There is some arrow, orange one, that is showing you where you should click. So there is the sounds. I don't know if everybody of you heard it. That means that we turn on and we start the ventilator after we put the electricity, after we have supply of gases, and we should choose a patient. We can have new adult patient, we can have new pediatric, or we can have neonates.
Aleksandra, are you sharing your screen yet?
Yes, I'm showing. I don't know.
No, it's not.
Oh, sorry.
Oh, no worries.
Share screen, but now maybe? No? I don't.
Not yet.
Like this?
There we go. Okay, I see screen share.
Oh,
there we go.
3 minutes with myself. Never mind. Me, myself, and I.
Now we found it.
You will have it. Michelle will provide it for you so you can practice it by yourself. We already started, so this is after we put the ventilator on and we choose patient. So I will put here new adult patient. I will confirm with the circle button, and there we go. Start. Confirm. We have tube. No, we don't want non-invasive mechanical ventilation. We want tube. He's showing you what to do with this orange arrow. I'm confirming. Telling us to go next. We put humidifier. We confirm. We have system check. We have accessory stages. And after this, when you set the basic things, you can go in alarm management in the main page. You can have advanced ventilation, and the very interesting, something that you cannot find in other simulation, is the special maneuver section. In the special maneuver, you have how to tube compensate the patient, because sometimes it's difficult to breathe with that tube who is long 20-25 centimeters. And in this kind of ventilator, you can put the tube compensation. That means that when the patient is breathing, the mechanical ventilator will calculate the dead space ventilation from the tube, will compensate that, and will show you if the patient is ready to be put it on some modus for weaning from the mechanical ventilation. Also very interesting. I will go there now. So we have ventilator setting. If we put patient on volume control, assistant control ventilation, I will confirm this one because he's asking from me. We go on the next one. We have additional setting dialog. There is the additional setting dialog, and we have the trigger, how much force the patient should use so he can breathe on his own. And we have active tube compensation, but we choose that one. We are saying that the patient is having tube, confirm that, and we will going to have help from the ventilation to show us if the patient is ready to be weaned from the ventilation. Other special procedure that we can have with this Drager-Levita simulation and mechanical ventilation is when we can see if the patient is having some condition in the lung. I will show you now. We have low flow pressure volume loop. When we put that one, you can read what does it mean. You confirm that you want to do that. You're activating the procedure. Now we will limit the pressure to 25 because we don't want to harm the patient. This 35 is a little bit higher pressure. So I adjust the pressure limit to 25. I'm confirming. We go next. Now we will limit the tidal volume to 800, not to have some volume trauma of the patient. This will be some upper limit. And when I have next, I will put the start button on. I will confirm it. It should be start inspiration. Now we are seeing in the diagram how it is calculating, how it is working, and in the end, we will open the analysis and he will show us how is the patient condition with the volume, with the pressure, and his patient is having some kind of infection. There is the lower, there is the upper that we achieve, and he is having very good compliance and the resistance of the lung, which is showing us that he is having very good condition, and maybe we can try to wean him from the ventilator. We'll close that. And the last one is the advanced ventilation, when you can practice how to put the patient on pressure ventilation, on volume ventilation. There is the flow. How much flow we want to have, we will adjust it, we will confirm it. Afterward, we will set. This is the main page of the ventilator. If you are remembering, I show you in one of my slides, we can adjust the tidal volume with clicking on the circle and we are confirming it. We can adjust the respiratory rate, and we have ventilation of the patient. 400 volume is a little bit low that I give him now, but should mechanical ventilation individually by every patient and his condition. I will close this now. You will have it so you can practice on your own. And now if you want, we have some time for